Our next speaker is Dr. Nada Alashkar. She's an associate professor of medicine at Johns Hopkins University and a transplant nephrologist at Johns Hopkins Hospital. She currently serves as chair for the Banff Glomerulonephritis Working Group. She completed her residency at Wright State University in Dayton, Ohio in 2004 in nephrology and transplant nephrology fellowship at Johns Hopkins and has been there since 2009. Her clinical research focus is on recurrent glomerular disease after transplant and high immunological risk kidney transplant patients. She's definitely multi-talented and recently published a book titled A Girl from the Middle East that is currently available wherever you get your books. Tells the story of her journey from Syria. And today she'll be discussing a significant problem in our field, recurrent FSGS after kidney transplant, an ongoing struggle. Dr. Alashkar, welcome.
Ready. Thank you so much. Thanks, Amira. I'm sorry about the technical problems. I really tried it before and it worked, but hopefully now it will work. So my topic is recurrent FSGS after kidney transplantation and ongoing struggle. And it's really a significant struggle that when we face patients with recurrent FSGS, we have too many unmet needs that we need to understand to manage those patients. And I'm sure all transplant nephrologists agree with me when they see those type of patients. Next. I have nothing to disclose. As I mentioned, I will discuss a few off-label drugs in this talk. So those are the objectives. It's really talking about our struggles. We need to understand more about pathogenesis of recurrent FSGS. What that means, we need to identify the circulating factors. Next, we need to understand more about clinical and pathological manifestations, how we can diagnose those patients early post-transplantation when the recurrence occur. And then do we have anything works to prevent those recurrence? And then we'll shed the light on what we have as treatment measurements. And then I will discuss with you the outcome of recurrence on the allograft survival. Next. So really this case, all those unmet needs. One of my lovely patients, she's now 41. She had no medical history before, diagnosed at age of 18 with FSGS. It's of course a primary disease, treated with prednisone, cyclosporin, Cytoxan, name it. She progressed very quickly. In 3 years, she was on dialysis, initially PD and then hemodialysis for a total of 3 years. In 2004, her mother donated to her. She gave her kidney transplant in another center. And the FSGS recurred very quickly in the kidney transplant. She really never came off dialysis. She had extensive plasmapheresis treatment and she remained dialysis dependent. Of course, with that, she became highly sensitized and shortly after that, she required nephrectomy. Next. She was sitting on dialysis, of course, for a total of 9 years. Nobody wanted to transplant her. She came to us. We enrolled her in desensitization treatment protocol, that study we did in the past. We don't really think it worked. However, she ended up getting deceased donor kidney transplant. She had low DSA level. She went home with delayed graft function for almost 1 month. She was on dialysis. We did kidney biopsy a week after transplantation. However, the EM was a little bit delayed because we did not think at that point with the delayed graft function that FSGS recurred that early. And then when we found about that, we brought her back and started the plasmapheresis and she received rituximab. At some point after she came off plasmapheresis and the treatment, her creatinine settled at 1.9 and her proteinuria was fluctuating between 1 gram to 5 gram per gram. She had several complications due to prolonged treatment with plasmapheresis and rituximab. However, her kidney lasted about 5 years. After the kidney failed in 2015, she was very highly sensitized with CPRA of 100%. So now the question, should we give her a third transplant? Of course, a lot of centers would say no. She had 2 transplants, both failed due to recurrent FSGS. Should we give her a third choice? So we did, actually. I fought for her and she ended up getting a deceased donor kidney transplant in 2017. Of course, with the new allocation system gave her priority as she was highly sensitized, we ended up transplanting her. With low level of DSA, really required only observation. Her induction with thymoglobulin, she was on full immunosuppression, MMF, tacrolimus, and prednisone, and she did not have recurrence so far. Now it's almost 4 years post-transplant, and she's doing well with creatinines normal and protein creatinine ratio of nothing basically. So she did so far well. So before I move on to post-transplant FSGS, it's really important to know the primary FSGS in native kidney, which is really the disease that we worry about in post-transplant. So of course, it's classified as three classifications: the primary disease or idiopathic that we need to understand more that recurs post-transplantation. As I mentioned in the case I stated before, it's acute onset. Very quickly, patients have nephrotic range proteinuria, progress very rapidly to end-stage kidney disease. A lot of patients do not respond to all the treatments that we have. And of course, we see very commonly the secondary FSGS that resulted from adaptation in the glomeruli to other insults such as diabetes, hypertension, etc. And of course, this is a very extensive field of understanding some causes of FSGS, in particular genetic mutation that leads to FSGS. Other causes are infections, and we start to see FSGS in patients who have COVID-19, in addition to medications as well. So primary FSGS is very highly common as the cause of nephrotic glomerular disease. It accounts for 35%. Very common cause of end-stage kidney disease accounts for 10% of the waiting list in USRDS up to 2013. And the primary disease can be manifested in 5 histological variants that we can see also in post-transplant. So that disease started with podocyte injury, as we all know. That podocyte and their foot processes is really the site of the injury. The podocyte is what gets affected by the primary disease, and whatever the circulating factor, permeability factor that binds to the podocyte receptors resulted in podocyte injury, manifested as podocyte effacement, and that leads to leakage of the protein in the urine. And of course, with that podocyte injury leads to the podocyte death and the sclerosis and helinosis that we see on light microscopy. So basically, this is really the center of the FSGS. So what do we know about permeability factor? We don't really know much. Those are a few of the permeability factors or circulating factor that we think they possibly cause the primary disease. Of course, we're all familiar with SUPAR, soluble urokinase, as potential or possible cause. Dr. Savine and her group studied cardiotrophin-like cytokine, which is one of the cytokine member of IL-6 that, and some data showed it's increased significantly in primary disease comparing to other healthy control, and can possibly cause FSGS or podocyte injury in the cell culture. Some people studied activase, protease, and some other circulating factors that studied. However, we do not know if it's one factor or multiple factors that lead to that primary disease. Here's what Dr. Reiser and his group studied as potential or possible cause of some subgroup of FSGS patients that SUPAR combined to the beta-3 integrin receptor on the podocyte, leading to podocyte effacement and injury, and later on death resulting in the FSGS and sclerosis on the glomeruli. As I mentioned, Dr. Savine and her group studied the IL-6 member. One of them, it's called CLC1. It found 100% greater in serum from FSGS patients and decreased significantly the nephrin expression in the cultured podocyte cells and lead to significant permeability of the albumin. Blocking of CLC1 results in significant decrease in the permeability to albumin. So it is possible one of the permeability factor that leads to primary FSGS. So move on to the main topic of our discussion today, recurrent focal segmental sclerosis post-kidney transplantation. So how do we classify post-transplant FSGS? The vast majority of cases that we worry about, of course, is recurrent FSGS, which is the main topic for today. And that most likely we think is resulting from the permeability factor that stays in the circulation and comes back and damage the kidney transplant. However, we see some cases of idiopathic, or we call de novo FSGS, that can be idiopathic. We don't know if this is the same circulating factor that happens after transplant, or some of the diagnosis was missed as in the cause of the native kidney disease, and that causing the FSGS post-transplantation. And of course, we don't forget that some of the viral infections that can cause FSGS post-kidney transplantation, and some of the medication we use very frequently in kidney transplantation patients that can also result in FSGS and manifest exactly like recurrent FSGS, but it's resulting from a cause which we call that, FSGS due to cause. And of course, we see commonly a few years after transplant that secondary FSGS that due to any insult to the kidney, such as rejection, diabetes, hypertension, or any chronic changes that we see that those. However, they do not manifest exactly the same clinically and pathologically. So those are, I just made this schematic summary of what we know about permeability factor. We talked about SUPAR. We published a few years ago about a case with FSGS collapsing, actually FSGS, that resulting from angiotensin receptors antibodies in a patient whose original disease was lupus nephritis. So it is possible cause of FSGS in some patients with recurrent or de novo FSGS. We talked about CLC1. And then some people, some groups study TNF alpha pathway as possible cause of FSGS. We also participated in some work of studying immunoglobulin. Next. We called FAST panel. It's just a group of antibodies that we found increased significantly in patients with recurrent FSGS, in particular anti-CD40, that showed area under the curve of 78%, differentiating between patients with recurrence versus no recurrence FSGS. And adding SUPAR to CD40, anti-CD40 resulted in significant podocyte injury and proteinuria. Here's some of the work that I mentioned is increasing significantly of anti-CD40 antibodies and that FAST group comparing to patients with no recurrence FSGS. And blocking anti-CD40 resulting in significant improvement or decrease in podocyte injury in cell culture. This data came from Indiana, that this group found that anti-angiotensin receptors antibodies was significantly high in patients before the transplant who later on have recurrence versus no recurrence. And the area under the curve was much higher comparing to SUPAR measurements before the transplantation. So hence that possibly in some subgroup that patients with high level of angiotensin antibodies are differentiating or predictive of recurrence post-kidney transplantation. Here's some work we did with a group in McGill in Canada that we showed TNF alpha was significantly activated in subgroup of patients comparing between patients who have recurrence versus recurrence. So we obtained sera from our patients with recurrence and applied it to cell culture of podocyte cell culture. And we found that significantly decreased the focal adhesion complex comparing to the patients who did not have the recurrence. Next. And when we add anti-TNF alpha medication to the sera, that resulted in significant improvement of or increase of the FACS, the focal adhesion complex sense. Hence, that in some group of patients, the TNF alpha may be activated and treatment of anti-TNF alpha improves significantly the outcome. So here we just published this data recently looking at patients who have anti-angiotensin receptors antibodies. We have identified 100 patients and we found 50% of those patients have either significant proteinuria or FSGS. So something that we never knew before that may shed the light on subgroup of patients as possible having anti-angiotensin receptors antibodies that resulted in FSGS post-transplantation. So that's regarding the permeability factor. Of course, all what I talked about is really does not explain all the FSGS recurrence post-transplantation. You may not find any of those biomarkers or permeability factors in any of our patients of recurrent post-kidney transplantation. So hence we need, I'm sorry, go back. So we still rely on the diagnosis of recurrence FSGS on proteinuria that we can follow patients with urine protein creatinine ratio can be confirmed by 24 hours. However, really that diagnosis relies on the biopsy and the EM findings of podocyte effacement. And of course, if recurrence FSGS happened later, or patients with post-transplant FSGS, that you need to rule out other causes, as I mentioned before. So the first sign of injury is the podocyte effacement that can be manifested only on electron microscopy. So we really don't need to wait to see the light microscopic changes before we say the patient has recurrence, because that's too late. When those are chronic changes when you see on light microscopy, and same variants we see on post-transplant. I need to emphasize that it's very important to diagnose patients when you see the podocyte effacement, not the light microscopic changes, sclerosis or hyalinosis that we see on light microscopy. So here's that podocyte effacement. That's significant in most of the times when you have recurrence FSGS. And this is the normal podocyte effacement that you should see in normal cases. Of course, when you diagnose in this stage, that significant part of the kidney that's gone, and when you see that sclerosis, the global sclerosis or segmental sclerosis. And most of the time when you see this, you still see significant podocyte effacement. Hence, you decide your treatment if you still see significant podocyte injury. So what's the risk factors of recurrence FSGS? As I mentioned, highly recurred post-transplantation, and different data showed 30 to 40%. Some of the risk factors, of course, that's familiar to you: rapid progression to end-stage kidney disease of the primary disease, young ages, as I mentioned in my case, low serum albumin before transplant. That's a clue that this disease is very aggressive before the transplant, and of course, prior recurrence in previous kidney transplantation, like the case I presented. We identified those published data as risk factors, and we found that 3 of those 5 risk factors in patients that associate with significant increase of prediction value with area under the curve of 72%. So white race, rapid progression, young ages, high albumin level, and previous transplant failure. If you have 3 out of this, that your predictive value increased significantly. Next. So how we prevent this? As I said, you see patients, you counsel them, you say, you have very high risk considering your risk factors. And I know probably 70% of chance that your disease will recur post-kidney transplantation. What can I do to prevent it from recurrence? Unfortunately, it's really nothing showed that any of these measurements can prevent the FSGS, as I'm going to show you in the data I'm going to present. So those are some therapeutic kind of preventive measurements that have been used in different data, and I'll show you the outcome. So plasmapheresis, rituximab, of course, ACE and ARB, the friend of the nephrology group, TNF alpha blockade, high-dose steroids, cyclosporin, and then some of the off-label usage is ACTH and B7 blockade. Prevention. This data came a few years, about 10 years ago now. We were really excited about giving rituximab a dose before transplantation to see if that improved the outcome. And this group showed that really that patients who received the 41 who received the rituximab dose, 27% of that, patients out of 41 who received rituximab at the time of transplantation showed significant decrease of the recurrence. Next. However, we did the prevention, our prospective data. This is data we published a couple of years ago on 66 patients, 2 of them de novo, and large number of patients, about 23 patients, about 62 of those have recurrence. They received rituximab treatment. And in this data was prospective study to see if their prevention with plasmapheresis and rituximab will result in decrease of recurrence. And as you see, 37 patients of our group has received either rituximab alone or plasmapheresis and rituximab. Next. Unfortunately, we really did not show in our data that rituximab or plasmapheresis or any of these prevention therapies decreased the recurrence of FSGS post-kidney transplantation. And the proteinuria was not any different. Furthermore, the survival of those patients who received prevention or not, or did not, or really did not affect the survival rate. So another data just published recently that also used rituximab in 12 patients out of 34 patients, and exactly the same. That recurrence rate was similar between patients who had rituximab as prevention or did not receive rituximab. Next. So far, it's really that prevention with plasmapheresis or rituximab did not show any benefit in decreasing the risk of recurrence FSGS. However, treatment, go back, please. Yeah. So what we do as treatment, it's still the gold standard of treatment is plasmapheresis with or without rituximab. And in our center, we use rituximab all the time. So in most part, what we do 10 sessions of plasmapheresis, and initially 3 to 5 in a row, and then followed by every other day for a total of 10 sessions. And some of our patients in this study received much more than 10 sessions, and the vast majority of patients received ACE and ARB. Next. So the vast majority using this protocol improved significantly, and we put them in complete or partial remissions. Only 5 patients really did not respond to this protocol. However, after we stopped this treatment, we have 14 patients, 40% have at least 1 relapse and require further plasmapheresis treatment or further rituximab doses. However, the vast majority of the patients responded really nicely to the further treatment. And we found that using rituximab in treatment decreased significantly the risk of relapse. And by the end of our study, only 8 allografts lost to recurrence FSGS. Next. In retrospective study that we published several years ago, we used the same protocol, basically plasmapheresis treatment and rituximab, and we found that treatment significantly improved the outcome and decreased significantly the podicide effacement once used early, and the vast majority of patients had significant improvement in eGFR. And also we measured serum suPAR and decreased significantly with this measurements. And we found using rituximab in this data decreased significantly proteinuria. Next. This is just the graphs of what I mentioned. Next. Another group published a couple of years ago, similar to our protocol using rituximab, comparing to their historical data that did not use rituximab, and we found the allograft survival is much better, and their remissions and to the treatment it improved significantly, and they had only 1 graft loss among 10 patients. Next, comparing to, and this showing improvement in their remission rates. Next, comparing to 5 out of 9 remission in their historical. So adding rituximab to the standard of care, including a plasmapheresis treatment only, and optimizing immunosuppression, that improved the outcome. Next. This data just came from French group. It's very large data showing that rituximab can improve the outcome on failure to respond to standard of care, which mainly plasmapheresis and their immunosuppression protocol, and also to take patients off plasmapheresis. So that improves significantly the remission rate. Next.
We're gonna have to wrap up in about 1 minute.
Sure. Okay, this is exactly the same I mentioned. Next. And then they found that rituximab really did not increase the rate of infection, which what we worry about in patients with several immunosuppression. Next. So this meta-analysis, plasma exchange is remained the therapeutic option for FSGS post-kidney transplantation recurrent. And in this meta-analysis, 71% achieve remission or partial remission. Next. In patients who don't respond to plasmapheresis or rituximab, we tried ACTH. Next. And we found 50% of those very resistant to respond to plasmapheresis or rituximab responded to ACTH after they failed all other therapeutic options. Next. Next, this is exactly the same. Next. And I think everybody heard about beta-7 blockade, betacept or belatacept that published in New England Journal in 5 patients. Next. We actually published responding to this data on 5 patients with recurrent FSGS, and we really did not see any improvement in the remission rate after using belatacept or abatacept. Next. French group also used it in 9 patients, and they showed no difference, no improvement. Next. Next. So we monitor the response by measuring SUPAR, and next. And we found that patients after plasmapheresis, the SUPAR level decreased significantly. Next. Next. And we found that AB5 activation decreased significantly in the podocyte culture, hence that plasmapheresis and rituximab improved significantly the podocyte injury. Next. And this is just the tissue culture. Next. Next, this is just lowering lipid in those patients, which is very important. Next, I'm going to jump to the outcome. I mentioned that in our study, 8 allografts failed out of 66. And the allograft survival, it's reasonably good in patients who responded to treatment. Next. Here's the TANGO study that published actually last year, showing that survival of the allograft worsening significantly in patients who did not respond to the treatment. Only a couple more slides. And this is Australian data showed that recurrence of FSGS occurs really early post-kidney transplantation in the first few weeks. And if those patients do not respond to treatment, the allograft survival is very poor. Very high number of patients that lost their allograft very early post-transplantation if they don't respond to treatment. Next. And here's the survival of non-responder is much less, as I mentioned. Next. Again, this data published a couple of years ago showing exactly the same. Allograft survival is much worse in patients who do not respond. Next. This is our data that we published on angiotensin receptors. We found that patients who have FSGS in this group have much worse allograft survival. My last couple slides. So I hope I convinced you that a lot of work needed in this field. We have a lot of challenges in managing those patients as a clinician and of course as researchers. So we don't know exactly what the permeability factor. We really need to identify it or identify all of them if different from patient to another patient. The diagnosis is very important. We need to find out how we can diagnose those patients early and treat them very well. Of course, prevention doesn't, prevention is, we don't really have a way to prevent the disease. We have few therapeutic options, however, not optimal and it's not successful on all patients. And the prognosis is very bad if patients do not respond to the treatment. And even those respond partially, the prognosis is not as good. And retransplant those patients is very difficult in many cases. Next, the final. So my summary or take home message, FSGS recurs highly post-transplant. We still monitor with urine protein creatinine ratio. We confirm the diagnosis by biopsy and finding on electron microscopy with podocyte effacement. Really the best options of treatment yet is plasmapheresis and rituximab. And then of course we have some other options as ACTH and TNF alpha blockade, but the response is not great in some patients. And I would like to thank the organizer for inviting me and happy to answer questions. Thank you.
Thanks, Nada, so much. I think we're a little over time, so we're going to go into our break. Thanks to all 4 of our panelists, Lyle, Raz, Mira, and Nada. Thank you so much and hope you all enjoyed the session. We'll see you back at 12:15 Eastern time and whatever that is Central time. Thanks again.